And Luka was growing fine, but yes, his bladder was enlarged, and his ureters, the tubes that empty his kidneys to his bladder, were enlarged. And it looked like there was a fused kidney like they thought up at Community North, but it didn't look like there was any fluid backing up in the kidney significantly yet at that point. And the fluid outside his body, which was one of the big considerations, was normal. He was getting stuff out through the penis, but the urethra through the penis was dilated. So we felt like we didn't have to do anything aggressive to intervene at that point, but just follow his growth. His growth's been great in the 82nd percentile, and he's kind of stayed right there. So he's growing despite this and doesn't seem to be bothered by that from a growing perspective. So we brought you back today to look at things again, and again, the bladder's enlarged, but his abdominal wall looks like it's doing okay in terms of tolerating that larger bladder. His ureters are still dilated. His kidneys have a couple of areas that have fluid backed up in the tissue of the kidney, but the kidney tissue doesn't look particularly bright like we talked about in the ultrasound room today. And he still has a low normal but normal amount of fluid outside his body, so he's still getting it out through the penis, but the urethra in the penis is still dilated. We can see that on ultrasound, and we can show the MRI pictures of it, so I can kind of explain that. So in general, we have this situation where that's all occurred, but we don't have any other specific diagnosis that we've been entertaining. You did have a low-risk cell-free fetal DNA in early May to check out certain genetic things, but we have not done any invasive testing like with an amniocentesis yet, because there hasn't been felt to be a big need, and you decided not to go down that road, which is fine. Mm-hmm. After birth, we can check in genetics if that becomes an issue. We can check on it. Does that make sense in terms of what you understand so far to date?
Yes.
Would it be helpful to see the pictures that they saw on MRI back in early May? It's been 7 weeks ago, but
yeah, I want to see.
All right,
yeah.
we can point that out.
Let me get my screen sharing. This would be, let's try it again. There we go. Okay, sorry, it was not cooperating. All right, you should be able to see my screen now, and there should be 4 windows that show different images. So each of these windows are different sequences and different planes looking through. Oh, I missed, do you have a name yet for your baby?
Oh, yes, it's Luka.
Luka, okay. So these are pictures of Luka kind of in different planes and orientations. So I'm gonna sort of talk you through kind of where we're looking and how we're looking. So I'm gonna start with this view. Let me zoom it up a little bit. So in this image, we're looking at Luka from the side. So you can see his head up here at the top of the screen. And then here's his spine back here. And then his bottom is down here, and then his legs, you can see one foot here, another foot here. So his legs are kind of keeping in and out of view. So I'm gonna go kind of right at his midline. So you can see the umbilical cord coming in right here. So this is where his belly button is gonna be. And I wanna point out this right sac right there that I'm outlining in green. And that is Luka's bladder. So normally a bladder is going to be well below the insertion of the umbilical cord. So it's going to be sitting kind of somewhere down here. And the fact that his is distended so much above the umbilical cord insertion tells us that it's large, it's enlarged. And then coming off of the bladder, going up toward the kidneys, are the 2 ureters. So those are the tubes that drain the urine from the kidneys down into the bladder. And if I'm going to move over to the side a little bit and show you, here is one of those ureters, and it is quite dilated. So I'm getting up to, at this point in time, was about 8 millimeters in diameter. Normally they're maybe 1 to 2 millimeters, if that. So his ureters on both sides. So this is going to be his right side. And then if I come over to the left side, here's part of that left ureter. Kind of draw down the middle of it. His left ureter is also dilated. So he's got a big bladder, he's got 2 big ureters, and then they're backing up into his kidneys. So I'm gonna switch views because I think this one is a little easier to make out his kidneys. So let me zoom up to make it bigger. So in this view, we're looking right through the middle of his belly. I'm gonna try and find a slice that's easy to interpret. So right here, we're kind of in his upper abdomen. The top of the screen is his belly. the bottom of the screen is his back. This thing I'm circling here is his spinal canal. And then you can see his stomach there, and then this other dark thing is his liver. So we're gonna go down from there. We're gonna kind of work our way from up high, and we're gonna work down towards his belly button. So going down, and now we're getting to the area where we see the kidneys. I'll go down a couple more slices, and you can see his umbilical cord coming in right here. So we're just above where that umbilical cord comes in. And here are his kidneys. So the left kidney is kind of sitting in a normal position. You know, it's sort of sitting back here. And typically we'd expect the right kidney to be sitting here and them to be separated. But his kidneys are fused together. And if I follow the parenchyma around, his two kidneys are fused, and so he's ended up with one kind of big unikidney, or we call it a horseshoe kidney. So he's got the two kidneys, but they're fused together. Let me delete that. And then if we keep going down, you can see that there's all this extra bright stuff that we don't normally see in the kidneys, and that's that fluid which is extending from the ureters up into the kidneys. At this point, he was so young, I can't tell you anything about how the kidney parenchyma itself looked. I know since this, on the ultrasounds, they've shown that he's had some cysts which have formed in the kidneys. But when the MRI happened, it was so early and he was so young and small that I can't really make out any of those cysts on the MRI. Okay? So then the last thing I was going to show you is his urethra. So here we're still mid-abdomen, and you can see this is his bladder here in the middle that's really dilated. These tubes that we see kind of twisting and curling around here, these are his ureters, both sides, that are dilated. So I'm gonna keep moving downward, and so here is an image of his penis and his urethra. So I've measured the urethra here in the middle. So it's this bright part right here. And then outside of that is the tissue of his penis. And so this is around where the tip of his penis is. And it is dilated, measuring about 7 millimeters. Typically within the penis, we can't see the urethra at all because it's so small at this point in gestation. So that this kind of shows you how enlarged and sort of tortuous his is, because we can see it and measure it. So if I start with the tip of the penis and kind of work my way back towards his body, let's go this way, you can see that actually all of these kind of tube structures are his urethra, and it's kind of curling around. His old penis is a little bit elongated and sort of twisting. I think this view is going to be better. I'm jumping back to that side view again of him. So I'll reorient you. You know, here's his bladder again down here, and this is his belly. And here is his urethra there. So this is the tip up here, and then you can see it kind of going up toward his body there. You can see how it's a little bit twisty from this direction, and here it is right there. We're kind of pushing it in cross section. And then from here, and then it goes into his abdomen, and then you can see it entering the bladder right here. So it's really, I mean, it starts off kind of small, and then as it gets closer and closer to the tip, it gets a little bit larger and more dilated. Also at this point in his gestation, given how tiny he was, I can't tell you anything about the muscles that form the penis. There are 3 muscles that sort of join together to form the penile tissue. He's so small, even in a baby with a normal size urethra, I can't make out those muscles. It's just too early for me to be able to tell you anything about those. Everything else on the MRI actually looked great. His brain looks perfect for his gestation age. Everything up in his chest looked good. You know, his liver, his gallbladder, all of his bones, everything else looked great. So that's what I had planned to show you. Is there anything else you want to see? Any other images?
No, I don't think so. You covered mostly everything.
Okay. I mean, I'll be here, so if you want to pull something up as the discussion goes on, I'm happy to do that.
Okay. Thank you.
Segue to.
Well, I wonder if it would it be most helpful now to know what happens in the delivery room, or what all these things that we're seeing on MRI mean for Luka? I'm gonna let you direct both. Okay, so we'll do delivery room piece. That's actually probably kind of quick and hopefully uneventful. So at the Riley Maternity Tower, there'll be a team that goes to the delivery separate than the team that's caring for you, and that it's called the Stork team. That's a team who gets trained, extra training in high-risk deliveries, and that would consist of someone like myself, quite possibly also a fellow, so a physician who could be a pediatrician outside in the world, but they want to be a neonatologist. We're a teaching hospital, as you can see by some of the individuals who have been interested in joining us here today, and so we have residents on that team. We have respiratory therapists who help us with any breathing issues, and then of course nurses and nurse practitioners. So a big team there for Luka. For any baby, even babies who we don't know any of this information ahead of time, the biggest issues they can have in the delivery room is usually breathing, because you're doing all the work for Luka now, and then when he's born, all of a sudden we have got to get his lungs filled with air and he needs to do the work. Some babies don't make that transition very well. What we're seeing doesn't suggest that he'll have problems with his lungs related to what's happening with the kidneys and urinary system. Because we're seeing a good amount of fluid, we're seeing the pictures look okay from that standpoint. But like I said, even babies without any of this going on sometimes don't do well in that transition of trying to breathe well on their own. So we can provide support if that's an issue in the delivery room. Hopefully for Luka it won't be. And so our main goal will just be stabilizing, making sure all the other things are looking okay, and then he will get admitted to the NICU. So that's one thing to anticipate and expect. And right now what we're thinking about and what we've talked about as a team is admitting him to the maternity tower NICU. So same building that you're delivering in, just one different floor. Because Dr. Kafer or any of his colleagues, his team, can come and see Luka in the maternity tower NICU. And if Dr. Gray or his colleagues are needed, they also can come over and see him there. So really from our standpoint, it will be stabilizing him, letting you see him, having that moment, and then getting him into the NICU and letting Dr. Kafer and his team know that Luka's been delivered, so that we kind of think about what steps are next for him. Of course, we'll do a really good physical exam to see if what we're seeing on these pictures are matching up with what we can see after he's born. And we'd let you know if there's anything different that we can tell in looking at him from the outside. But then it'll be kind of getting the other subspecialists involved to kind of talk about what are the next steps for him. What questions do you have just kind of about that immediate process?
I just think the next steps are what we're concerned about.
I bet. Those are the big ones, right?
On him. Is he going to need surgery immediately?
Right.
Is there a time? That's our scare.
Right. I
Absolutely.
think Dr. Kafer would probably be able to.
Yeah, he will definitely
weigh in on
fill in
this
some of
part.
those holes for you.
Great, if now's a good time, I can begin. There's been so much good information given to you, and it's been very thorough, so I don't want to repeat too much of it. But what I did notice is one thing you had mentioned was about the kidneys being fused together and how we wouldn't separate them. There's no reason to, actually. Both kidneys we'd anticipate will function just as well fused together, and we would always leave those alone and doing well. As you've seen now and in previous visits, the entire system that produces urine and then evacuates urine is dilated, is bigger. This can be bigger for a number of reasons. What the data suggests is that the area of obstruction, or well, no, what we should say, inadequate or incomplete passage of urine is at the end of the penis. There could be a actual true narrowing. It could be that the tissue there simply isn't transmitting the urine across that site as effectively because the urethra is different. The bottom line is that when the baby's born, we will obtain an ultrasound of the baby and see how the kidneys and bladder look. We'll then place a catheter in the urethra into the bladder so we can get a urine sample and also decompress things. And then if the baby then remains stable, which we anticipate they will, we at some point would put some dye in through that catheter in order to outline the system and see it more clearly than we've seen it so far. There's some great pictures up till now, but that picture will really give us even better information. Some possibilities at the time of delivery is that I may not be able to easily put a catheter in through the penis. If not, don't worry. There are 2 or 3 other things up my sleeve that we'll have available to drain the bladder. But we'll anticipate getting that catheter in and then discussing with you what we see on those additional imaging studies. Any questions so far? Is that clear?
That was clear.
And you're saying never, if his kidneys are fused together like they are, there will never, he can grow up and grow old with fused kidneys, and be fine.
Correct. Yeah,
Okay.
absolutely. Any one of us in the room could have fused kidneys right now as well, and it wouldn't make any difference as long as they drain and function well. The real question is going to be, how well do they function, since there's been this apparent obstruction of the system? And blood tests will tell us that and give us a baseline as to how well these 2 kidneys that are together are working to clean the child's blood. And I wish that I had more that I could tell you that I knew about this, but as of right now, what you've heard is what we understand. And it'll take until the baby is delivered before we can give you any further detail on this anatomy. Any additional questions that come to mind at first?
I have a question. Previously, in one of my appointments, they mentioned that the baby's spongy tissue in his penis might not grow properly because of the expanding urethra. Is that something that you think he'll need surgery on in the future?
Sure. I would say that it's not a matter of cause-effect. We really don't know if one has a megaurethra, whether it's the expanding urethra that causes the penis to have an abnormality of its tissue, or whether the penis itself, the tissue, is the thing that's going on. The bottom line is, at the time of delivery, we'll be able to see that and know it. And if a certain aspect of the penis isn't present in normal proportions, we can do things to improve upon that.
Thank you.
A pleasure.
One thing I forgot to mention is starting an antibiotic, a small dose antibiotic after baby's born, so that'll help try to prevent infection. So that'll be something that doesn't happen in the delivery room, but once Luka gets admitted to the NICU and we order the ultrasound and all those things, that'll be one of the orders that'll get started.
Does it matter
for
that
him.
father is allergic to penicillin?
No, we will
Oh, yeah,
still
that
go
was-
with our primary choice, but it's always nice information to
Didn't know
pass
if
on
that was the
to have that.
antibiotic we were using or not.
So thank you for sharing that piece, but, and it's amoxicillin is the antibiotic, or an IV version, depending on kind of what's going on with Luka.
Cord blood and genetics.
Yes, there was a genetic plan in place that talked about holding cord blood, so collecting blood from that umbilical cord. And based on what I saw in the counseling notes, their initial thought was to send a whole genome sequence, so kind of a big, let's collect a big, huge amount of information to see if we can pinpoint something. But what we typically do is we get that cord blood, and then we have the genetic doctors come meet Luka and make sure that that's the exact thing that they want to send. So that'll be something that we'll be able to do after he's born.
And that's to show if there's anything wrong, right?
If there's any genetic
Wrong.
thing that could be connected to what we're seeing with Luka. Sometimes there is, sometimes there isn't, sometimes we really think there might be, but we still can't find that particular thing. So what it looks as if, what's all the information we have right now? And 5 years from now, we may gain more information that helps put some of the pieces together. But it is an attempt to see if there's something that we know about that could be connected to what we're seeing with him.
When the genetics docs come, they'll do a physical exam on him, because there could be features that Luka has that we can't see on the MRI or ultrasound very well, like on the outside of him. So they'll do a physical exam and look at all his imaging and stuff, and come talk to you guys before they recommend what genetic testing they think would be prudent.
was your feeding plan or goal for Luka? What had you envisioned?
Like breastfeeding.
Okay, because that sort of ties into how Dr. Gray and his team kind of might be connected in, the pictures early on, the colon, as they talked about, looked a little bit small, so part of the intestines, but it was very early in Luka's gestation. So our goal will be to see how he tolerates feeding. So all the things that Dr. Kafer talked about are gonna be that kind of first priority, but then we will support you in your goal of breastfeeding. And as long as there's not something that requires a surgery where he can't be eating at the moment, then we'll see what he does. And if he's having issues, then we may have to look from below to see if something's abnormal with some studies, and then connect in Dr. Gray or one of his colleagues if we're seeing things.
Yeah, the idea about that is that on that early study, like we said, his large intestine looks to be small, and it's hard to know for sure what that means. If it's abnormally small, or if it's just kind of what it was at the time and it's got to get bigger. Sometimes there are some syndromes that kind of go along with having this abnormal urinary bladder system and also having a very small large intestine. So that's just something that we have to see what it's like when he's born.
His uncle had that,
Oh yeah.
and then no openings in his belly.
Okay.
So at a month old, they went in and made opening here and opening there.
So he had to
So
something there.
everything could go to it.
Gotcha. And so there's a potential that Luka may require some kind of operation, if that's the case. So, if we see that he's eating but things aren't going through well, his intestine gets kind of dilated, then we do some studies, mostly x-ray studies, sort of like Dr. Kafer was saying, where we can put contrast dye, like liquid that shows up on x-ray, we can put it into his bottom and go up the large intestine and see what it looks like. And then some babies require surgery to go inside and explore in the abdomen and see if there's a blockage somewhere. And if there were, that's something we can usually fix. Or sometimes have to bring up the end of the good end of the intestine to the surface for a stoma, so that the baby can poop out and he can poop and eat normally until he's a little bit bigger to go back in and reconnect things. So those are possibilities.
That's like a colostomy bag.
Mm-hmm, exactly. So they're all temporary possibilities, but possible. So we just kind of look and see how he eats first, and then if he's not doing great, we kind of work up some of these other things.
Dr. Kafer, would you rather us hold off on feeding until you've got to see him and evaluate? What would you prefer? Just so I can give Mom a good sense of what we might do for him right after.
Yeah, I think we'll be able to come by and see the baby within the first hour of delivery. So why don't we take a quick look at the baby?
Okay.
And we'll let you know our thoughts immediately.
So we'll just check a blood sugar to make sure that that's normal, and as long as it's okay, then we can avoid putting an IV in and fluids and kind of give. So initially we won't have him try to breastfeed, but the nurses are great at getting you pumping. So that's telling you about, oh, this is what I'm supposed to be doing, and we save every last drop. It's liquid gold, so don't worry, that could be his first feedings, just while we work through some of these kind of immediate things. And then once we get the clear to try to give a shot at letting him breastfeed, as long as he's not requiring any significant respiratory help or support, then we can support you in trying to get that goal going.
And our goal is to make it full term, right?
Yeah.
Mm-hmm.
Fingers crossed.
So, any other questions about the delivery room or what's gonna happen afterwards in terms of evaluating him from a urinary standpoint, a surgery standpoint, feeding standpoint, all that's pretty clear?
Yeah, it's clear.
You're doing prenatal care with us now, is that right?
Mhm.
So we'll keep up the prenatal care. He's growing great, and so I don't feel like we need to do any antepartum testing at this point because he's growing so well. But we'll probably keep an eye on his growth with ultrasounds, keep an eye on his urinary tract with ultrasound on a monthly basis, just kind of keep an eye on that.
You mentioned early on about how long he'd be in the NICU. That's a question we can't quite answer. So once we meet him, see what he needs, see how he feeds, then we'll start to be able to give you a better idea of how long he'll have to stay. So I wish I could give you a little better ballpark.
I didn't know weeks, months. I didn't
Right,
know.
so once we get to know him, then we'll be able to help fill in that a little bit more for you. He will definitely be here, still in the NICU, when you're ready to be discharged. So that's what you can anticipate, unfortunately.
Yeah, I think your biggest determinations of that will be how well his lungs work, which we think they'll probably work okay, and then how well his kidneys work. after all this thing. I think those are the two areas that can make someone stay for a much longer time otherwise. And then the intestine is there, but probably not as important as those other two organ systems.
Our aim would be to let you get all the way to 39 weeks when his lungs would be as ready as possible, and then we could talk about getting him delivered. We have to watch for preterm labor, because that's always possible, but babies with structural birth defects like this, of any organ system, have a little bit higher chance of going into preterm labor, so we'll teach you how to watch out for preterm labor.
Okay.
And see if anything like that happens. But if we get you to 39 weeks, then we can talk about, depending on how you're doing and how Luka's doing, potentially getting you into the hospital, getting you delivered, get you induced.
She just found out that she has heart murmur. Is that gonna affect any of her delivery?
Shouldn't. Who found it?
My physician.
Your family doctor?
Family
Yeah.
doctor.
Gotcha.
Well,
Yeah.
I'm glad you mentioned the heart piece. The echo was fine before, but they did recommend an echo after Luka's born, just to look at the right ventricle. It's a non-urgent, so it's not something that has to happen the moment he's born or even the day that he's born, but it's something that'll just be on our list to do, and it's just based on the recommendation from what they saw early. So that'll be something that happens, maybe a couple days into his stay. We'll just get that and then share it with the cardiologist.
Okay.
Okay.
Does Dad have questions? Is he still on?
No, he's not.
Oh, that's
He's on,
Just
okay, I
recording.
didn't know,
Yeah.
oh, you're just recording, it.
Yeah.
That's right, it wasn't that he
Yeah.
was actually on.
You can call Ari afterwards if he has any questions.
Okay.
Yeah,
Sounds good.
yeah, and since you're getting prenatal care here, as you come for visits and stuff like that, if you have any questions, just let the team know. Keep an eye on Luka. That's about it, unless you got other
Alright.
thoughts or questions.
So I'm flying to Florida this weekend.
Cool.
Is there any risk, or is that a problem?
Sure,
or
ready to
anything?
go.
It shouldn't be if you're not having any symptoms of preterm labor, so contractions, leaking fluid, or bleeding.
Okay.
Yeah. How long are you gonna be going to Florida?
Just 4 days.
Okay.
She's going down to take pictures of baby bump on the beach.
Oh.
I said, you can Photoshop those.
I like the way you think.
Come on.
Just drive up to the dunes,
Put on one of those filters, right?
Yeah.
You gonna be near a major city?
Yeah. I'll be with my mom too.
Yeah.
So she'll be taking the
Which she's
pictures
been
and.
to the appointments with her, so.
Yeah.
Yeah.
Cool. Just don't get sunburned.
Yeah, that's right. It's hot down there.
And there's a hurricane headed that way, just so you know.
Well, thank you guys so much
Yeah,
for
thank you.
everything.
Thank you.
You're welcome.
Appreciate it.
You guys.
Get your ultrasound scheduled.
Thanks, Dr. Caper, thanks, Dr. Forrest.
Okay, thank you.
Thank you.
Thank you.
Nice to meet you.